I'm super excited for some of the data that's here at ASH 2024 in San Diego. There's a lot of new data with small compounds in myelofibrosis. I'm particularly interested in the data with elritercept, which is a TGF-beta superfamily inhibitor, which inhibits activin A, but also GDF8 and GDF11. And we're presenting at this meeting the updated results from the RESTORE study, looking at this agent in combination as a monotherapy. As you know, in myelofibrosis, there are many unmet needs for our patients, and one of those is anemia, but the other is really true disease modification. Our patients can get a long way with JAK inhibitors, and we've now got 4 approved in North America, 3 in most of Europe, but 4 in North America. And so the management of anemia and improvement in the bone marrow niche, improvements in the platelet count are really big unmet needs. And in the study with elritercept, we noticed some of these aspects being improved for patients, both in the monotherapy and in the combination cohorts. And so we've recruited an extra 32 patients in the dose expansion study. The agent looks to have good tolerability, most adverse events relating to thrombocytopenia and diarrhea. And in line with the study, which is a little bit further ahead in MDS, we see efficacy in terms of significant reduction in transfusion burden for patients. Also important in myelofibrosis, some reduction in spleen size, even in patients that are already on ruxolitinib, and improvements in symptoms. And many patients, even those with quite severe thrombocytopenia, so platelets less than 50, maintaining or slightly increasing their platelet count. So this is important at a time when we know that many patients continue to benefit from JAK inhibitors. So most recently, the most improved JAK inhibitor is momelotinib, but still many patients continue to have some spleen and some symptom burden and some anemia. So this potentially is of great interest and is a good combination partner because it appears to be well tolerated. But we will need to wait for more news on how does it look on the bone marrow niche, what's it doing to other parameters of disease. So in 2024, coming into 2025, the choice of JAK inhibitor can be confusing for colleagues and also for patients. So it's very much personalised. In Europe, of course, it's very linked to where the approval status is, but in general, for a patient that obviously has a platelet count less than 50, then the choice is either momelotinib or pacritinib. And I think the NCCN guidelines have slightly different categorization for those 2 agents. If a patient has more of an anemic profile, then I might go for momelotinib, although pacritinib also has some activity against ACVR1. The data with both compounds is relatively mature. And there's some very nice data presented at this meeting looking at a sort of matching analysis, a sort of MIC analysis, looking to see is there survival benefit with momelotinib, and also there's a first appearance of sort of real world data, so some data coming from the UK, from Spain, but also from Moffitt Cancer Centre as well, showing that actually in the real world setting, patients are still continuing to get anemia benefit, which is really important and a very prevalent problem for myelofibrosis. So yeah, I would choose based on baseline platelet count, whether the patient has significant anemia or is likely to become more anemic with a conventional JAK inhibitor like ruxolitinib or fedratinib. But if the patient has a big spleen and a big symptom burden, I think many of us would still be looking to ruxolitinib and then thinking about adding on an agent perhaps to ameliorate anemia. And so we're all waiting for the results of the independent study, which is luspatercept plus ruxolitinib in a randomized fashion, which will be important, and we should expect that later in the year. Meanwhile, in the quest for something that can do more for our patients, at this study we've got updated data with BOREAS, which is looking at the MDM2 inhibitor navtemadlin. And there is the launch of the POESIS study, which is their kind of phase 3 study looking at registration. That's an interesting study because it looks at suboptimal response, taking patients that haven't achieved their target and then randomizing. So that's a new way of looking at approvals. Another agent of interest in myelofibrosis is selinexor, and there's some updated results with that agent at this meeting, and also the Sentry study, which is their phase 3 study. So we're at a time when we've got newer phase 3 studies coming, and as listeners will know, we've also had 2 in inverted commas failed phase 3 studies in myelofibrosis looking at combinations in the frontline setting. One agent, navitoclax from AbbVie in the Transform-1 study, no update at this meeting. But the second agent, pelabresib from MorphoSys, now in partnership with Novartis, there is the update with the 48-week data at this meeting, which is being presented as a poster, so listeners can look at it online. But the data still looks reassuring with strong benefits still on spleen, also benefits on symptoms, although that missed statistical significance. There's a further analysis of that. And as colleagues will know, there was a small concern about potentially higher rates of leukemic transformation. So there's an update on that on the poster. From my perspective, that's still relatively low number of events, and whilst we're continuing to monitor patients, for me, if say the data was flipped the other way around, I wouldn't be saying that pelabresib reduces the risk of leukemia, so I'm not so sure it really increases it, but time will tell. The study in progress, well, that's about to launch anyway, looking at momelotinib with luspatercept, because there's still a gap. Whilst many patients will retain or attain independence from transfusion, there are still some patients that are anemic, still needing the occasional transfusion, so there's still room for improvement there, and there's good tolerability, and as we know, we can see luspatercept having activity in MDS. The other agent I think is of interest, and with newer data coming, is imetelstat. Thinking again of something that's been approved and evaluated in MDS and also in MF. And so there's the ongoing study with imetelstat compared to best available therapy in the second line setting, and then a really interesting study of combination of imetelstat with ruxolitinib. But the overwhelming problem we have in the myelofibrosis field is what our endpoints should be, and that's a conversation we need to keep having and data we need to keep looking at. Endpoints may be still related to spleen, but there are other attractive things that we could be looking at, such as molecular responses, maybe bone marrow fibrosis, although that's very subjective. And I think we need to move more on that as a field, and that will help us to select winning strategies for our patients. The problem is an overall survival endpoint is a longer study, so we need to find a surrogate for overall survival, and we need to collect all of the data. In PV in the UK, we recently showed in a study called the MAGIC PV, which we published last year, that in patients with PV, which is JAK2 V617F driven, if you reduce the mutational burden by 50%, patients have an overall survival advantage. And you can do that with a JAK inhibitor like ruxolitinib, or of course you can do it with interferon. And so that's potentially of interest and could be carried forward. And it's very relevant in the field as we've got the development, no update here at ASH, but the development of mutation-specific therapies such as the CALR therapies from Incyte and J&J, and then the JAK2 V617F and pseudokinase domain-specific inhibitors, which I think are really of interest. And so we'll have to probably redefine our endpoints when it comes to them.